I'm Dr. Fakir Rawari, and this is pharmacokinetics and pharmacodynamics of aminoglycosides in adults. Our first learning objective is, given a patient with stable renal function, calculate estimated creatinine clearance using the Cockcroft-Gault equation. Because aminoglycosides are almost exclusively cleared renally, it is important to be able to assess renal function. Let's take a look at what happens in the nephron. Generally speaking, there are three things that happen: filtration, secretion, and reabsorption. Glomerular filtration is a passive process that occurs in the Bowman's capsule. During this process, water and small ions and molecules, including drugs, diffuse passively into the lumen. Secretion is an active process that occurs mostly in the proximal tubule. There are many transporters involved that secrete substances into the tubule. And finally, there is reabsorption, which is also an active process, and it mostly occurs in the distal tubule. The best way to assess renal function is to measure glomerular filtration rate, or GFR. Now, you can either measure GFR or you can estimate it using equations. Measured GFR is the best index of renal function. And when measuring GFR, we want to use a substance that is filtered only and is not secreted and it's not reabsorbed, because we are only measuring the filtration process. Inulin is a substance that's clinically available and is used primarily by nephrologists, but it's not routinely used in clinical practice because it's expensive and it's not readily available outside of nephrology. Therefore, oftentimes we have to estimate GFR, and there are equations that we can use, including MDRD and CKD-EPI. These equations are validated in patients with CKD specifically, and MDRD tends to underestimate GFR in general. So CKD-EPI happens to be a more accurate equation compared to MDRD. Another thing that we can do to assess renal function is to use creatinine clearance as an approximation of GFR. And just like GFR, when it comes to creatinine clearance, we can either measure it or we can estimate. The way that we measure creatinine clearance is by actually collecting urine. Typically, the best way to do it is to collect urine for a 24-hour period and then get a urine creatinine level as well as a serum creatinine level, and use this equation to get the actual creatinine clearance. As you can imagine, this process of collecting urine for 24 hours might not be practical. And if we collect urine for a shorter period of time, let's say over 4 hours, it becomes more practical, but it reduces accuracy. So another thing that we can do, we can actually estimate creatinine clearance using Cockcroft-Gault equation, which typically overestimates GFR. Again, creatinine clearance is only intended to approximate GFR, so it is not an actual GFR. Some limitations of creatinine is that creatinine, not only is it filtered, but it's also secreted and eliminated by gut bacteria. It depends on muscle mass, nutrition, age, and drug interactions, and it typically lags in the setting of acute renal change. So creatinine clearance can only be used in stable renal function. Here's how this equation was developed. In the 1970s, two colleagues, Cockcroft and Gault, did a study at the VA which included 96% male patients, and they did 24-hour urine collection, and from their data they derived an equation. And because most of their patients were male, they did a correction for deriving an equation in females. Again, avoid use of this equation in patients with unstable renal function. For example, if the patient has AKI, this equation is not valid, because in this study that they derived this equation, everybody had stable renal function. Although in the original equation they used the total body weight, it's been suggested that total body weight may not be the best estimation for every patient. So typically we actually calculate ideal body weight, which are these equations. When it comes to patients who actually are less than 60 inches tall, it's suggested to use these numbers for ideal body weight. Of course, you should always use clinical judgment. One thing that I have seen clinicians do is, for example, if somebody's height is 58 inches, they would use a -2 in these equations to actually subtract. There are no universal guidelines on how to approach this in different patients, so you may work with different clinicians who approach this differently. For the purpose of this class, we will use these equations. You might wonder, what about patients who have had amputation? For those patients, you can actually use this chart in order to subtract from the ideal body weight whatever limb they're missing. For example, if somebody had below the knee amputation, you can actually subtract 6% of the ideal body weight that you calculate. These numbers are just for your reference, so you do not need to memorize these percentages for patients with amputation. For patients who are obese, and obese is defined as a BMI of greater than 30, or a total body weight that is about 20 to 30% over, or I should say at least 20 to 30% over ideal body weight. And the reason there is a range here is because different studies have used different cutoffs. So some studies have used 20 as the cutoff, and some studies have used 30. Again, there is no universal guideline on how to do this, but these are the ranges that are typically used in clinical practice. For the purpose of this class, we will not have a case that's in the middle of this, so you will either have a patient whose total body weight is more than 30% or less than 20%. And then for the actual equation to calculate adjusted body weight, there are different factors described in the literature. Again, for the purpose of this class, we're going to use the 40%. So we're going to use this equation in this class to calculate adjusted body weight. But I'm just showing you that there are other equations out there. So when you are in on rotations, you may work with preceptors that may use different equations. So again, there is no universal guideline on what you should do. You should use your judgment. And for this class, we will use this equation. And of course, when it comes to bodybuilders, you know, even though their BMI may look like it's too high, or if their total body weight is more than 20 to 30%, that's typically their muscle. So you may not actually have to calculate adjusted body weight, but always use your clinical judgment. So going back to the Cockcroft-Gault equation, if someone is underweight, meaning that their total body weight is less than their ideal body weight, you should use total body weight in the Cockcroft-Gault equation. Someone who has a normal weight, meaning that they weigh at least their ideal body weight, but less than 1.3 times the ideal body weight, you should use the ideal body weight in the Cockcroft-Gault equation. And of course, someone who's obese, and for the purpose of this class, we're going to use the cutoff of 1.3 times the ideal body weight. You should calculate the adjusted body weight and use the adjusted body weight in the Cockcroft-Gault equation. Now, these are for the purpose of this class. You know, there are no universal guidelines. So if you come with, you know, always follow what your preceptor tells you. And of course, beyond graduation, always use your own clinical judgment to decide what to do in your practice. And of course, there are clinicians who round serum creatinine of less than 1 to 1 in elderly. You know, a common thing that's out there is if a patient is 60 years old or older and serum creatinine is less than 1, I have seen clinicians round it to 1 just because elderly have less muscle. Because of less muscle, that serum creatinine might artificially be low. Now, in the literature, this is generally not recommended because you tend to underestimate creatine clearance. So it is not recommended to round serum creatinine in elderly. Now, there are situations that you may need to round. So, and in the literature, it's recommended to round to 0.8. So if serum creatinine is less than 0.8, rounded to 0.8. Not necessarily for elderly, but for malnourished, because serum creatinine comes from muscle. So if someone has low albumin or low protein, that could be an indicator of malnutrition. Or someone who just happens to have very low muscle mass, for example, or someone who's paraplegic. For those patients, you may round serum creatinine of less than 0.8 to 0.8, but still use your clinical judgment.